I'll serve today as your host and moderator. This webinar is being hosted by the Primary Care Collaborative, and just a couple of words about the Collaborative. It's a nonprofit, multi-stakeholder organization that unifies and engages diverse stakeholders and promotes policies and shares best practices to support the growth of high-performing primary care, which is what we're going to be talking about today. This is a membership organization with over 60 organizations committed to its mission and supporters. And it's dedicated to advancing effective and efficient health system that's built on a strong foundation of primary care and the patient-centered medical home. Before we get started, I just wanted to give a few housekeeping reminders. As I think you've already heard, you're all muted, so please submit questions in the question box. And we're not going to answer questions until the end, but please feel free to send them in at any time. And the webinar is being recorded, and the recording and the slides will be posted within 24 hours. And just to give a little tiny bit of overview, I wanted to talk about our topic today, which is team-based care. And team-based care is one of the shared principles of primary care and part of PCC's vision for advanced primary care. And more than 350 organizations have embraced this vision. And it's a necessary feature to achieve comprehensiveness and equity, among other principles. And what we were talking about with team-based care is that in a practice center, leaders need to assess how a team meets patients' needs and consider various logistical, infrastructure, and payment frameworks. And I think we'll touch on some of those today. And we're going to be talking today with some really great panelists about who the players on a primary care team are: physicians, nurses, and other clinicians, behavioral health specialists, and pharmacists, and other kinds of care coordinators, and different kinds of people playing different roles. And we're going to talk about how team members can function well together and what they do to provide high quality, comprehensive, and equitable care for their patients. Talk about who leads a team, how does leadership shift depending on the context, and what's the latest evidence about what makes a team work well, what contributes to team effectiveness. I'm interested in this topic. I have been interested in, how primary care is delivered and what makes it work well for a long time, and have done a little bit of my own research in this area, particularly collaborating a couple of years ago on a paper that was led by Hannah Napresh at the University of Minnesota, also with Laura Barry-Smith and Bethany Sheridan, who was then at Athena. And that was looked at just a little sliver of this and really looked at the way that MDs and nurse practitioners specialized and differentiated their roles. We used the really rich EHR data from Athena to look at practices that had both kinds of practitioners to see how did their roles converge, how were they different, and we were able to look at characteristics of patients, of visits, and of diagnoses, and we learned some interesting things. One of the things we learned was that nurse practitioners compared to MDs really did tend to see slightly different kinds of patients. They were more likely to see younger patients with commercial health insurance or Medicaid, less likely to see Medicare patients. They tended to see patients for longer periods of time and were more likely to have same-day visits. And we also found that in terms of the diagnoses, there was actually an awful lot of overlap. 92% of diagnoses were ones that were, used by both kinds of practitioner, but there was a subset of sort of more intensive clinical services that were more likely to be provided by MDs. We couldn't tell from our data whether these practitioners consider themselves to be providing team-based care versus just co-located in a practice. So we were just scratching the surface of some of these things, but it's made me very interested in learning more about how people that are providing primary care function. And so I think we're going to learn a lot today. And this whole, I think, environment is changing so quickly, and there's so many new models of primary care that are being put out, recently, whether we're talking about the more kind of retail-based models or some of the things happening in Medicare Advantage. And of course, there's so much increased use of a virtual platform now. So I think that what a team can be, there are a lot of different models, and I think we're going to hear about some really great examples today. So I'm going to just tell you a little bit about our panelists, and then I'm going to let them introduce themselves and give brief presentations each, and then we're going to have a little bit of a moderated conversation, and then we're going to throw it open to questions from the audience. So I'll briefly read each panelist bio, and then I'll turn it over to the first. And I think we have just a fantastic panel today. The first person that I'm going to mention in order of their presentations is Dr. Andrew Diamond, who's the Chief Medical Officer of One Medical, which is certainly a very, very interesting new primary care model. And through the course of his tenure, he's been a driving force in developing the practice's philosophy and approach to care, designing its clinical systems, and maintaining its human-centered culture. He's a practicing primary care physician and works to ensure that the clinicians at One Medical have a joyful and fulfilling career, that sounds great, and deliver the highest quality care and service to members. So I think that will be really great to hear how teams work there. And then we have our next guest is a panelist who's going to be talking about another really new sort of exciting advanced primary care model, and that's Dr. Tony Makrich, who's the Vice President of Pharmacy Services for Catalyst Health Network, which is a really interesting nonprofit from Texas. And it's a URAC accredited, clinically integrated network of more than 1,000 primary care providers. And Tony provides leadership for the organization's care management and pharmacy services. So he's going to talk about the role of a pharmacist in teams. And he holds a PharmD from Ohio State and brings more than 15 years of leading operations and strategic performance to multi-site, multi-state organizations to his role. And finally, our final panelist is also a clinician and a physician, but she's got a little bit more of a researcher orientation. And this is Dr. Christine Aronson, who's co-director of the National Center for Interprofessional Practice and Education. So she's really an expert in interprofessional education and can sort of see how teams work from a different perspective, where she leads the strategic direction of this center. And she serves as the alumni professor and chair of the Department of Family and Community Medicine, or was, at Thomas Jefferson University. As a family physician and geriatrician, Dr. Aronson has provided a lot of team-based care herself, and she has extensive collaborative practice experience and a demonstrated commitment to interprofessional education. So that is a great lineup, and now I'm going to turn things over to our first presenter, who's Dr. Andrew Diamond. So take it away, Andrew.
Thank you, Catherine, and thank you to my fellow panelists and to the Primary Care Collaborative and to for organizing this, and thanks to all of you for joining and listening in. I'll just take a few moments and just share a little bit more about One Medical and what we are trying to do, particularly now in a merged practice with the great folks at Iora Health, who are now part of the One Medical family. One Medical was founded in 2007 by a practicing internist. I was lucky enough to join right around that time, coming right out of my internal medicine training. And really the vision in those days was, let's fix the entire American healthcare system by transforming primary care and thinking about primary care very differently, both in terms of the patient experience as well as the team member experience, the clinicians, but also the other folks on the team who help create the experience for the patients and for one another. So we wanted to reimagine all of it. And we also wanted to invent or reinvent all of the technology that contributed to that employee and that patient experience. Because in those days, the technology was really pretty abysmal, none of it being purpose-built for primary care, certainly. So One Medical was founded really as a medical practice, but also as a technology company and sort of a management services organization, really all of those things. But we were in our infancy, just a single office in San Francisco when I began. One Medical has grown now to have well over 100 offices all over the country in many major metropolitan areas. And now in post Iora merger world, we have closer to 200 offices all over the country, and serving a much broader population. So we're very, very excited about our growth and the variety of patients that we are now able to serve. But fundamentally, we remain a membership-based practice. So the members come to us because They want the model of care that we offer. And every year they're saying, yes, this is my primary care practice. So they are engaged in that way. We have, from the very beginning, created and maintained a team-based model, which begins with the relationship between the patient and their primary care provider. But because we are all over the country, the patient is able to walk into any one medical office if they happen to be traveling or if they've relocated and get the same kind of experience. The energy in the office is one where, regardless of one's role, everybody is treating everyone else with respect. Everybody is on a first name basis. The clinicians are not wearing white coats or referring to one another as Dr. Diamond. Everything is very collegial and friendly and supportive. We have a virtual medical team that is working behind the scenes using our technology platform to take care of everything from sort of the more mundane tasks that most clinicians think, I wish I didn't have to do these things, like responding to normal lab results, renewing prescriptions, dealing with some sort of just real-time triage type issues, all the way to much more sophisticated and really complex primary care, including management of chronic diseases, diabetes, hypertension, and the like. That team includes health coaches, care navigators, nurses using protocols to care for patients, physician assistants, nurse practitioners, and some physicians who are all working 24/7, 365 to take care of our members virtually. And again, it's a really highly collaborative environment. And now, in partnership with IORA, we also have a new type of team that we are welcoming into the One Medical family and starting to learn from, which is the idea of a pod that is really focused on senior care and helping to manage the total medical expenses for a senior population through daily huddles, really focusing on transitions of care, hospitalized patients, specialty care, and so forth, and managing all of that very thoughtfully. We have daily huddles to talk about our operations, new clinical guidance that we are creating on a daily basis through our nationwide team. And all in all, very proud of the quality of care and the quality of experience that we've been able to deliver, and look to be delivering for far more folks in far more places in the coming years. So I'll stop there and pass it back to Armand.
Hi, thank you very much. I think we can go now to Tony Mackrich.
Hey, good afternoon, everyone. I echo Andrew's sentiments about thank you for having me on. Again, I'm a pharmacist by training, and we work for Catalyst Health Network, which is a large group. We're based out of Dallas, Fort Worth, and it's a group of around 1,100 independent physicians. And my role is to oversee a clinical care team that supports these physicians. And I have two slides. I'm going to walk through a little bit about how our care team is set up, how it interacts with patients, and how it supports the PCPs, and some of the cultural ways that we do that. And so you can see there's 4 blocks across the screen here, connected to physicians. So we have a clinical pharmacy team that is patient-facing, that does not dispense any medications, and then a team that does your more commonsensical pharmacy dispensation work. And those two teams are separated within the organization. And we start with connected to your physician. So the way that we set these up is, as patients are referred over to us from the member physicians, we have EMR access. So we're directly connected to those physicians and working in that native system so that it's an easier communication pathway between the pharmacy team and the physician. And then from there, medications, we clinically optimize them. We do what's called a comprehensive medication assessment, which isn't your normal medication reconciliation that you would see for a patient who comes out of a transition of care. This is a deep dive into all the medications that they're taking, over-the-counter drugs, their belief systems, to really make sure that we're understanding what the potential roadblocks are for that patient so that we can optimize that regimen for them. When I talk about roadblocks, potentially there are three key ones that we see. The first one is that educational one where they have a complex medication regimen. They don't truly understand how that medication regimen should be implemented. And also there are some, confusion to how the medication regimen ties to the disease state. The second one, and I think this one resonates with a lot of physicians, is the financial, where you want to put a patient on a certain medication, but that medication is $200, $300, $400 because it's not a preferred medication. And there's no real way for physicians or the practices to know what's covered and what's not. We have the ability to go through and send multiple medications through in the same drug class, and then provide that link again through the EMR back to the physician and get that patient quickly on the med that makes the most sense and removes that financial barrier. And then lastly, logistical. A lot of the patients we see are on 8, 10, 12 chronic medications, all filling at different times throughout the month, and it's multiple trips to your pharmacy or multiple packages in the mail from your mail order. And we take the medications, we sync them up so they all fill on the exact same day, package them in adherence or compliance packaging, and then have a courier service that delivers it to wherever they want, their home, their office, etc. And they can track all that on the app. So really making it simple. They understand their regimen. It's as effective but as cost prohibitive or least cost prohibitive as possible, and then getting those meds directly to the patients. Third bullet point there or box is you are known here. Our model is set up differently where if you were going to call into an online pharmacy, you don't know which pharmacy you're going to get, which pharmacist you're going to get. We have specific patient assigned and practice assigned pharmacists to build the relationship with the patient. The trusted relationship is kind of the backbone for our services to really make these patients feel comfortable with us and move them forward on their journey to wellness. And then built for how you live. We customize outreaches, we customize dispensing, anything that they need to make this easier for them, we tweak those types of things. So it's really a comprehensive from clinical all the way to getting medications delivered to that patient's door process that we have. Next slide, please. Can we flip to the next slide? Oh, if it doesn't go forward, I can continue to walk this. So there are truly three then services that we offer our patients and support our physicians with. There's medication management, which again is that clinical interaction, medication optimization, and weekly to monthly check-ins with those patients to identify areas where the patient has issues, needs, concerns, and then quickly through the EMR help with the help of the physician in the practice to overcome those. It's longitudinal monitoring, so every month those patients, perfect. I'm starting in the middle here. Well, we lost it. It's monthly outreaches prior to their dispensing of their medications to assess any needs that the patient may have. We've seen patients where their medications have changed dramatically, and we will check in with them in 30 days, and they're having some side effects for a medication and they stopped taking it. And we ask, have you reached out to your physician to let them know? It's no, I don't want to bother them, right? And so they will just plan on, I'll see them in 90 days from now and we'll talk about it then, and not be with their medications, right? So that monthly check-in creates some stickiness with the patient, continues to build the relationship, and then drives the clinical outcomes. And then on the far left-hand side of that slide 5, I know it's not showing here, is medication monitoring. And so we were talking a little bit earlier, medication adherence is a very important measure, both clinically and from a quality standpoint, especially in the Medicare space. And we have a team that's dedicated to following patients, helping them to overcome barriers, pick up their medications, whether it's with our pharmacy or any other pharmacy, to make sure that they're adherent to those medications to avoid adverse reactions, adverse events, or increased cost in care. And then lastly, that medication dispensing. Like I said, we cover the last mile. We have a delivery courier service dedicated to this that gets the medications literally to the patient's door, same day or next day, to really close that. So it's sort of that Amazon-based medication delivery right to your door with a very strong relationship-based pharmacy component coupled together to drive these outcomes. And then I will pass it on to our next speaker.
Well, I want to echo Tony and Andrew and thank the Primary Care Collaborative for inviting me to be here today, and thank all of you who've joined us, and really excited to come follow these three great colleagues. I think you've heard so many examples of what we know works in teams to improve primary care and the experience for our patients and really quadruple aim outcomes. So we know a lot about how teams impact primary care for the good and really impact those quadruple aim outcomes. So the experience of care for patients, the quality of care we deliver in health of populations, the overall cost of care, and more important than ever as we're living through the COVID-19 pandemic, the experience of care for the team. We learned a lot from the initial patient-centered medical home demonstration projects, and particularly the TransferMed work, which was published now, I think, 12 years ago in 2009. And we continue to learn every day. I think the models that you heard from Andrew and Tony, the Aura and One Health models, I think are great examples. The work that Tony's doing with pharmacy, and they didn't tell you a lot about their outcomes, but I know they have. They've shared with me some of the really remarkable outcomes they've achieved, both on behalf of their team and on behalf of the patients that they're serving. There's really rich work that's come from comprehensive primary care transformation, particularly out of the University of Utah's Care by Design work and the University of Colorado's patient-centered medical home transformation work that has taught us a lot about what outcomes can be achieved in terms of improving patient outcomes and costs with improved or at least stable patient satisfaction. We have really robust literature on the value of integrated behavioral health in primary care. We have this emerging literature on the value of pharmacists as part of the primary care team, community health workers. I think we're about to see a renewed interest and research in integrated oral health in primary care and the impact that that will have on people's overall health. So this is really exciting and positive. We also know, however, again, going back to the TransferMed work and confirmed many times since then, that this is not easy and it's not cheap, that it takes a lot of resources and sometimes skill sets that we don't have, certainly that I didn't learn in my family medicine residency within our practices. So we know that it takes time, and coaching can be very helpful to helping practices really transform and look at their own team and how they can function better. We also know from the UCSF data that we may improve the experience of care and quality of care for patients and the experience of care for the providers, physicians, nurse practitioners, and PAs, unfortunately at the expense of other members of our team. And I really appreciate Andrew calling out the whole team, because we also know from the burnout literature, Tate Shannenfeld's work, that if one member of the team, a medical assistant, resigns, the impact on the physician who worked with that person is profound for the next year. So we have to be thinking about caring for our whole team as well as for our patients and communities. At our work at the National Center for Interprofessional Practice and Education, we really define our core work as within the nexus of education and practice, and are really focused on the human factors that help teams to be successful. So we need technical solutions. We need electronic health records that work for us and for our patients and our teams. We need checklists and all the kind of technical tools that help us. We're going to see what AI brings in the next years, but we also know that bringing people together, even with a superficially shared purpose, does not necessarily lead to effective teamwork. And we have to look at the human factors that help future health professionals, which is often what people think of when we talk about interprofessional education, but frankly, also the continuing professional development of practicing teams, to understand where their strengths are and opportunities, and also where they may need to do some work, and where coaching and other tools may be helpful to bring them along. So our work is really based on a model that was developed out of the Institute of Medicine, now the National Academies of Medicine, in 2015, looking at the impact of interprofessional education on collaborative practice and outcomes. And we really look across the continuum of practice to drive towards the quadruple aim. So outcomes that matter to patients, really starting from the needs of patients and community, and also recognizing that we don't all have a pharmacist in our primary care team. We don't all have integrated behavioral health yet. We don't all have community health workers. So starting from the team that we have, how can we optimize that team in practice? And we've been fortunate to work with informaticists and the Clinical and Translational Science Institute at the University of Minnesota to develop an information exchange that allows us to help practices collect readily available data that addresses all those domains. How is the team working together, and where do they need to work developmentally? And also, what are outcomes that matter to that team and their patients? And we're using this right now in a real world setting as one example with the network of family medicine practices at the University of Minnesota, where Jim Picala, my chair at Minnesota, is really driving adoption of the Institute of Medicine age-friendly system and the 4 M's, the 4 things that matter in geriatrics care. And our tools are supporting their looking at iterative, really implementation science from pilot practices across a network of 40 family medicine practices. So we're very excited about this opportunity, and I look forward to talking more about it and the really exciting models you've heard from my colleagues in our conversation. So I'll turn back over to our moderator, Catherine.
Thank you. Hello, everybody. That was wonderful. I'm really looking forward to having some conversation. And I think I'm going to start with something that I think everybody touched on, but I'm going to ask Andrew to answer first. But I think that everybody talked about certain aspects of teams, and there are obviously, many different models of team-based care and primary care now. There are a lot of new entities like One Medical, like Catalyst, and then there are existing networks of practices that are really trying to transform themselves by investing in a lot of new practices. So, I think it's probably fair to say that there are, more than one modalities of having a very effective team, and I think that's something we'll be kind of digging into. But I just thought we'd start by saying, what do you think are some of the essential characteristics of a successful team? And I thought, Andrew, I thought you might be able to comment a little bit about your merger with Iora, and they also had a successful team-based model of care. And I was wondering if you might be able to talk about what are some similarities and some differences, and do you feel an urge to try to hone to one model, or can you sort of live and let live and say both of these models work very well? And then I wonder, from the Catalyst perspective, I know you have many practices in your organization. I wondered if you might be able to comment on what are hallmarks of successful practices. And then I think, Christine, you'd be able to give a really nice overview from all the things you've learned about. So I think I'll step back and throw it over to Andrew and see what you have to say.
Well, thanks, Catherine. I think some of what I'll say probably will sound almost trite, but it's still entirely true. You know, the essential features of a high-performing team, it's the people and the way they treat one another on the team. And I think we just have to be very, very careful about bringing the right people together and creating the right environments for those folks and having the right behavioral norms. You know, I think like a lot of folks in the world, in America, where everybody's kind of being reminded of like kindergarten level basics about what, you know, a good team looks like from like Ted Lasso. You know, it's like, let's just treat each other well and not have people bullying their colleagues. And so we've always felt at One Medical that really our most important asset, if you will, are the people in the organization and the sense of community that we build here. And I know that our new colleagues from Iora Health feel exactly the same way about their teams. It's really it's first and foremost about the people and about the behavioral norms and the culture of mutual respect that, you know, when we have a disagreement, that we discuss it in a collegial way, as opposed to wrist slapping and that sort of thing. Because inevitably, there will be differences in treatment decisions or other decisions made about a patient or about some other aspect of the practice by an individual. And ultimately, what matters the most is how we learn from those differences of opinion or decisions that we might not personally agree with. So that's the most important thing. We have also found that, and this is probably no surprise, having regular team huddles that conform to a particular structure with a dashboard so that there's a predictable cadence to that and a predictable set of data that you're looking at, with perhaps rotating leadership so that every week or every day, perhaps, the person facilitating the huddle changes, and it can include any member of the care team. I think that's a really valuable approach, and that is common across organizations. While there will be different team priorities in the Iora offices, where they have a team that's entirely focused on the care of seniors in Medicare plans, we will have those teams continue to do the things that they're good at doing and that they're accustomed to doing, and the One Medical offices will, or what we'll call the legacy One Medical offices, will continue to do things the way they're doing, and we plan on learning from one another over time. So it'll be a multi-year integration in terms of the way the teams start to come together. A lot more other integration work that we're quite far along on when it comes to other aspects of the combined business. But I think the most joyful thing about, sorry, I'm borrowing metaphors here, but playing in a big league with all these different offices and two great organizations is the opportunity to learn from one another and the joy that is associated with that, right? I mean, it's just, if we think of it as a team sport, to go back to your opening slide, really the title of this entire webinar, sports are a joyful thing. We love playing on teams and we love learning from the games. So that's kind of how we're thinking about it now. Maintaining that joy in practice, I think, is just essential.
Perfect. And I think the second part of the question was, how do you implement this successfully? Catherine, I think was kind of the question that you asked. And so, as representing the team that's receiving these referrals, we do a lot of education to the physicians and the providers to really help them understand what's going to happen to the patient. What we've learned is, hey, I'm going to refer you to my pharmacist, and your pharmacist is someone that just hands you your pills at the counter at CVS and says, you don't have any questions, do you? And walks back and is too busy, right? And this is a very different approach. So we spend a lot of time in practices to help get everyone comfortable speaking to the patient on what's going to happen, because they look to that PCP as that trusted resource. And if the PCP is like, I don't kind of know what's going to happen here, it doesn't go well, right? So there's a lot of back-end education to get everyone comfortable with having this conversation about that referral. And then our physicians that do this very well, they've changed their mindset where this is a standard of care, right? I've got a patient who's hyperlipidemic, hypertensive, uncontrolled diabetic. You know, that's the standard of care. As much as getting an A1C drawn for somebody, it's I'm referring you over to this pharmacy team that's going to work with you. That's kind of the first thing. The second thing that our great physicians do is they don't think, why do you need these services? They think, why don't you, right? And so if Andrew was a patient that was being seen, it's, you know, his A1C is close, but I don't know. They will refer those patients. And if it doesn't make sense, that's okay. The patient doesn't have to accept. And then I think the last things are, you know, you're educating everyone so they understand what's going to happen. And then you're referring it to standard of care. And then the last piece, Andrew, you mentioned it too, is metrics, showing them how they're doing. You know, a lot of times we'll say, you know, how did we do last week? I'm like, you sent us 2 patients or 3 patients. Like, I felt like I did a lot more. And just reinforcing those behaviors to get it to become second nature. And then I would say lastly, and it's more of a technical, the EMR is just the best way I can say through all these things to really be a conduit of communication. And I say this all the time, it's native. The PCPs and the providers are using it, and they don't have to jump over here or jump over there. So getting the care team integrated into the day-to-day workflow is really important. Those 3 things, if you have those, you generally will have a very successful connection to the patient. We just need the patient to know that the PCP is sending them over to us, and it's not just some random, you know, robo-caller or somebody that's spamming them. If you connect the patient and the pharmacist together with the PCP at the center of that hub and spoke, this thing goes very well.
So Catherine, maybe I'll just pick up. I think, so I'm the academic in the group, but I think Andrew and Tony just described, I was actually making check marks. Everything that I would say we know from the literature, you all are successful. It affirms my literature that what you're doing is making you successful is what I thought should be. I think your first question is there, you know, kind of one ideal team? And I think Andrew kind of mentioned the different patient populations in the IORA practices versus the I'll say legacy One Health. And I think that's emblematic. There's not going to be one size fits all. Rural is not going to be the same as urban, as suburban. When I was at Jefferson and we had 100 practices scattered over about an 8-county region in southeastern Pennsylvania and New Jersey, everything from solo practitioners to very large, the practice I worked in where we had literally 50 providers and 30 residents with very different patient populations and different needs. So I don't think there's one size fits all, but I do think there are core principles, and it starts with culture change, which I think both Andrew and Tony talked about. And then the need to treat each other with respect as, you know, human beings each with a particular set of expertise. From the person who answers the phone knows something about the patient that the physician is never going to know because they have a different kind of interaction, and everybody in between. Both of them talked about the need to really understand the roles and responsibilities of different members on the team so that you can engage the right person at the right time. Both spoke to communication and having effective lines of communication and feedback to make sure they're working. And then the things that I think, shared leadership, another critical factor that I think both of them mentioned, Andrew very specifically, you know, the right person on the team for that moment in time for that patient taking leadership. And then what I think they both implied that I would just articulate explicitly is a shared mental model of what the goals are for the patient and a shared vision and a shared set of values. And I'm hearing loud and clear that both organizations have created those, and we know those are critical. Even when everybody kind of knows we're here to do the right thing by the patient, if we're not explicit about it, our idea of the right thing for the patient may not be this, mine might not be the same as yours. And then you can have that constructive conflict because we have different pieces of information and we can really put that all together for the patient. And then I would just say the sort of next gen thing, and you all may be doing these, Andrew and Tony may both be doing these very well, and we just haven't talked about it, but that we're really interested in at the National Center is how do we move from doing the right thing for patients to doing the right thing with patients, and move from sort of a desire to have patient-centered care to really bringing the individuals and communities that we serve in to co-create that care together that meets their needs.
That's fantastic. I just want to follow up on one thing that Christine said, and I think you all really referred to is the importance of this as sort of a culture change, and the metaphor of playing on a team sport and the joy of being on a team. I think a lot of us, and I know all three of you are physicians, a lot of us think about physicians as being kind of bred to be very independent, not to want to be employees. Med school is kind of a lot of tough love and, getting knocked down and picking yourself up and having an enormous amount of sort of cultural authority and not necessarily being a team player. So I guess I'm curious to know, is it an especially tough adjustment for physicians versus some of the other non-physician team members? And do you feel like sort of the med school culture is starting to adapt the way it grooms new physicians so that they're more ready to engage in this kind of a care pattern? Anyone can
I'm happy to jump in on that one quickly. I mean, I think that your description of medical training is apt. I actually think that the folks who generally pursue primary care, by and large, reject that type of grooming, and that might be part of what pulls them toward primary care. And just the nature of primary care itself. There's at some point in your training or early in your career, you realize like you absolutely cannot do this job without a team. You can't be an army of one in primary care. Many have tried, but it really requires a team mindset. I do think that from what I'm seeing, medical education and particularly primary care training has very much shifted towards creating practitioners who are less in that sort of cowboy renegade mindset, my way or the highway, much more team player kind of folks coming out of medical training in primary care now.
Yeah, and I would add from the pharmacy side specifically, I think 10 or 15 years ago that may have been more present, but the way that the schools are designed now, and Andrew and Christine, I don't know if this is how you've seen it, but the pharmacists and the dentists and the physicians or the PCPs are all coming up through med chem, biochem, anatomy, physiology together, and then they transition into their own schools. But then when they start their residencies and rotations, they're back again, kind of in a collaborative team. And so I think that the connectivity there is thread throughout the schools, at least what I've seen, that when these physicians are coming out of school, they have something to dock back into the value of these other positions that they had seen along the way, and the cowboy mentality is kind of broken, I think, a little bit because of that connectivity.
Yeah, I'm so glad that both of you are seeing that, because that's certainly what the goal is. We do now have required attention to interprofessional education it's required by the LCME for medical school accreditation, and in fact, medical schools are being held accountable for that, as well as 25 other health professions. Pharmacy has certainly been at the leading edge of that historically. How that gets implemented at each school is very different. The team experience at schools is very different. Although I do think we have data, we have data that we know that health profession students come in expecting and wanting to work on effective teams. On the other hand, even though most of them have been on teams somewhere along the way, sports teams, they have not necessarily made the jump to the skills that made a team, you know, a soccer team work effectively to a healthcare team. So we do need to help them with that. I do think primary care residency education, you know, the impact of the patient-centered medical home movement is very real in primary care residency education. And I think, you know, I was actually just privileged to be invited to co-author one of the papers that as family medicine is looking at a major rewrite of the residency accreditation standards around the role of interprofessional education and getting these team working skills. So I'm really pleased to hear that those of you on the ground are seeing that impact. But I think, Catherine, your description of the historic culture of medicine is right on, and it's bad for physicians. So we have to help people get past it. It's bad for physicians and it's bad for patients.
So we've been having a lot of fun so far because we haven't really talked about money very much. But now I'm going to bring up some questions. You know, I'm going to ask sort of a few different questions, and I'd just like everyone to kind of, you know, jump in. And then I'm going to ask one more question about patients, and then I'm going to see what the audience might have in mind for y'all. But in terms of kind of the financial aspects, I'm curious about, you know, payment models. I, you know, sort of feel like a lot of the impetus for transforming primary care is driven a little bit by putting physicians in a position where they can take risks for total cost of care and don't have to become maybe hospital employees. I don't think that explains everything at all. So I guess I'd sort of like to ask about two aspects of this. Well, three things. One of them is, how important is it? Does it hinder the feeling of cohesion if there is sort of a payment model where everybody stands to, you know, to be sort of responsible for certain outcomes, and the team, you know, the team members are sort of joined in that way? How complicated is it when you have many different payment models with many different insurers, and you're seeing kind of a mix of patients, and you don't have the same incentives for all of them? Does that make it harder to have sort of consistent team practices, or are there lots of spillovers that other people benefit from team practices that their payer isn't necessarily paying for? And then finally, it seems like plans are starting to kind of fiddle in this world a little bit more, introducing virtual platforms, getting into the provider space, you know, through ownership, but also sort of, you know, having different aspects, especially sort of virtual care platforms. So I wondered if you could just sort of comment a little bit about how the sort of the joy and the team sport interacts with the financial aspect of providing primary care.
Well, I can jump in here. I mean, I think there are a lot of questions in there. I would summarize them all as, you know, it's the $1 trillion question for America. Can we actually figure out how to do this well and save $1 trillion a year and actually get high quality team-based primary care paid for? I mean, in the interest of time, I'll say this. Our thesis is that primary care teams, if freed to do what they know is in the best interest of the patient, are going to do a good job regardless of what is happening in the background and reimbursement. So our thesis is, let's figure out how to take lots of different kinds of reimbursement for whatever is available in the community. Where there are opportunities to take risk, let's do that. Where there are opportunities to work with employers on a PMPM basis, let's do that. Where we have to work directly with payers, let's do that. But let's do our best to insulate the care team from all of that stuff, so that the care team can really focus on the factors that are most important to the health of the patient and the community. Now, obviously, you can't do any of that if you can't get paid. And I think that the most important factor for unifying those two worlds, the world where the care team focuses on the patient and you're working with all of this complexity in the background, is to do it at scale. And so that's why you're seeing organizations and entities like One Medical and others starting to flourish, is because there's an intent to do this at large scale, so that you're not relying on a small practice to manage all of that complexity over and over and over and over again everywhere across the country.
I would very much agree with that, Andrew. That was certainly our experience. I was working at Well, as at Jefferson, I believe for several years we were the fastest growing healthcare system in the country, and that was certainly a driver in how we were able to help practices transform, is that we could take that concern away from the practices and take it back at an administrative level at scale. I don't think there's one right model. I think it's very interesting and courageous, perhaps, that the National Academy's new report on primary care is recommending that we pay teams instead of physicians or providers. And I think that's very interesting. My own bias is fundamentally, I don't know that it matters how the team is paid, but we need to have enough resources for primary care to be unleashed to do what it can do for the country. And then it is a $1 trillion question for the country, as Andrew said. I think that's spot on. If the teams are resourced, I'm not sure that it matters so much how the money is coming in, as long as there's enough of it to do what we can do.
Yeah, and so I would just add a couple of things. From the outside of the practices looking in, it's very difficult when we're out trying to drive, quality metrics across multiple payment models and multiple contracts. And I come to Andrew and I say, hey, we need you to drive this for your Aetna patients and this for your Medicare patients and this. And after a while, it's just, you start to see a glazed over look, and it's like, I just want to take care of patients. So one of the things that we do is we try to insulate the care team from those things, as you mentioned, and have a liaison person that works with the practices to say, we find commonalities, right? And there are things that you're going to see commonalities, HEDIS, CMS measures, where you've got A1Cs and blood pressures, and here's just the list of people that need a mammo or a colo. And it doesn't need to tie to a payer or a payment model or a contract. And it's more engaging because it's just practicing medicine, right? And that's what everybody who's a clinician really wants to do there. So I love the way that you guys are saying that. And one of our biggest challenges that we see all the time is, how do we continue to drive these things forward with all the administrative contractual differences between the two? And that's how we've done it. Care team, care services, and really focus on those patients with some metrics that are driving what we need to do, right, to perform, to get paid. And then having another team that's practice facing, that's really working with those things, and the liaison between the two teams.
Thank you. That's really great. I have one more question. I mean, I have a lot more questions, so I'm only going to let myself ask one more question. That's my own, which is, I'm thinking this is all about patients, but I think, to use another sports metaphor, this is really inside baseball in a way, because I think the average person doesn't have any idea of what team-based care is, or advanced primary care, or a lot of these things. Now, I think that people might look at a One Medical or a Catalyst and say, hey, this is kind of new. This entity seems to have a different business model, and it's different, and I'm choosing this, and I can sort of see some of the things about it. But I don't know if they would even know this is team-based care. And there's a lot of sort of untapped power, because we don't necessarily have consumers saying, I demand this, I want this, and I'm willing to pay more for this, or look for this, or get this. I mean, I think we have that, but it's in its infancy. So I guess I'm curious, what your reaction is to that, and if you think, is there any way to sort of, explain these attributes of the care that you can provide to people, so that they will, seek it out and demand it, and probably benefit more from it?
Well, I'll just jump in very quickly, Catherine. I agree with you in terms of how many, people in the world really think about, or they just assume this is how we're practicing and don't understand all the challenges. It's actually something we're actively looking at right now at the National Center, and in collaboration with primary care academic folks at the University of Minnesota, is to start to understand what patients do understand about team-based care and what their priorities are, and ultimately, hopefully, create some kind of a tool that can help practices, get that feedback from their patients about how the team is working or being perceived by their patients, in addition to sort of the standard patient satisfaction data, which doesn't really quite get at that for us.
And I was just going to add one thing from a tactical standpoint. I talked about how when we go in and we kick these things off to engage practices, we have some education and scripting and verbiage. And literally care team is woven throughout that. You know, my care team, I have a care team. I'd like to connect with my care team. My pharmacist is a part of my care team, my social worker. And so that word comes out, or those words come out a lot. And then we've gone so far as to when we're outreaching patients, it says literally care team when we call them on their caller ID to connect them again. And then we're introducing ourselves as, you know, hey, I'm Tony. I'm a pharmacist that works with Dr. Diamond as a part of his care team. And so they've heard it from the PCP, they see it on their phone, and then they hear it from us when we talk. And we constantly reinforce that. So it's a much more micro scale of that of the patients within our ecosystem. But what we've seen is a husband that signs up and the wife's like, wait, you have a pharmacist working with you and a social worker that's helping you, got a blood pressure machine, and you've got somebody working, a dietitian. I want that. And we have these, well, we'll get one referral, but we enroll 2 people. And it's because they see the value of this care team. And so we just continue to kind of espouse that internally and preach the message out to the physicians in the network to help us with that.
The only other thing I would add here is how important I think technology will be in helping people understand the care team. In the same way that, you know, Facebook groups are kind of come together, a lot of the experience with primary care in the future is going to be digital first. It's going to be what you see in your app, and that we have an opportunity through that technology to more clearly explain who's on the team. Again, you know, to our earlier point, putting the patient really deliberately on the team at the center of it, and then making it very clear how all of these other people and programs kind of come together to create that team-based experience. So I just think there's a lot of fun we're going to have with technology, thinking very differently about that patient experience and bringing the team together.
That's great, and I think that more and more patients are going to, you know, be looking for these kinds of interactions with their providers. I know we're almost out of time, so there was an audience question, and I'm sure there were others, and I apologize to the audience. But there's been some interest about whether the possibility for integrating oral health more fully with advanced primary care and really seeing oral health as part of primary care. So curious, you know, maybe Andrew, Tony, ask you first, and Christine, from your perspective, what are you hearing about that, or what are the barriers, or what are the prospects?
It's definitely something that we have always thought would be interesting to work on as a future state. I mean, there's no doubt that oral health is very important for overall health. There are several dental practices that are popping up around the U.S. that we are flattered to think are sort of in that sort of one medical model of a redesigned experience. You know, I think in the immediate term, it's more about making sure that we get sort of our core stuff right. But I think the sky's the limit in terms of how we could integrate.
Yeah, I wouldn't have anything to add. I think you summed it up pretty well. Yeah, it's what are the key things first, and then focus on those, you know, moving forward.
Yeah, I would say from a national perspective, you know, there's been a kind of waves of interest in integrating oral health, but I think we're on a rising tide right now. HRSA has invested in a primary care center of excellence around integrated oral health, which I think is demonstrating some interesting findings. I think the federally qualified health centers, because their payment model is so different, has included oral health, have figured out models that we can learn from in other insurance, you know, in other payer mixes. I did not have a dental school with me for my career at Jefferson, but since I've moved to the University of Minnesota, the dean of the dental school there is actually very interested in this, and I work almost every day with one of the dental faculty who started a new profession in Minnesota, which is dental therapists, who are perhaps ideally situated to be in primary care practices and do sort of basic oral hygiene and oral health, and then, you know, have a referral source to dentists. So I think we're going to see more about models that are feasible. You know, The insurance system has been completely fractured, so that's, you know, an added challenge. But I think over the next several years, we're going to see some significant movement to models that may actually be sustainable for the typical primary care practice to integrate oral health. We certainly know it's important for people's overall health.
Agree, and it's the lack of access to dental care certainly in the news lately. Now, I know that we are officially out of time. We got some great questions that we didn't get to today about how to engage patients, how to adopt this to rural settings, how do we measure that it works. I hope that these audience members might want to follow up with, with any of our panelists, and I wish we had had more time, but the time, it went by really quickly, and I really enjoyed talking with all of you. I learned a lot, and I think it'll definitely impact some of my work going forward, and I hope that I get a chance to see you all again and hear how you're doing. And just, I want to thank everybody for tuning in to our webinar today. And I think with that, we're gonna wrap. So thank you, everybody.
Thank you, Catherine.
Thank you all very much.
Appreciate it.